very good morning to everyone. Thank you, Tashini and Sherini. Tashini, that was a very, very interesting interesting case. I really miss going into clinics and doing everything else, So I'm Sasheela, Ponnampalavanar, an ID physician who will be moderating the second session. We will now shift gears from that very interesting clinical case to address one of the most pressing challenges, not only a global healthcare community threat, but also a threat to our daily practice, which is antimicrobial resistance. Actually, this week we celebrate the World Antimicrobial Awareness Week, which is observed annually from 18 to 24th November to raise awareness, promote understanding, and encourage best practice among all stakeholders to combat antimicrobial resistance. So as you all know, antimicrobial resistance is going to undo decades of progress in modern medicine. Okay, and even AI won't be able to help us in this because resistant infections are going to make common conditions such as pneumonia, surgical site infection, skin and soft tissue infections, and others increasingly difficult to treat, and we all face it today. So during the national launch of the World Antimicrobial Resistance Week yesterday by our Honorable Health Minister, he highlighted an alarming statistics whereby Malaysia is projected to witness 87,000 deaths from 2020 to 2030 if no significant intervention is made to combat antimicrobial resistance. So this figure is equivalent to 0.25% of the country's population of 33 million and underscores the severity of the issue as documented in a study by the WHO Western Pacific Region Office. So the Ministry of Health Malaysia, along with the Ministry of Agriculture and Food Security, has initiated various measures under the Malaysian National Action Plan against antimicrobial resistance. But what can we do as healthcare professionals in our little hospital? Well, there are two key areas where we can make an immediate impact. One is use antibiotics appropriately, meaning the dose, use it for the right reason, don't use it for viral infections or just in case reasons. And also number two is to adhere to infect prevention measures consistently. So this year, the WOW theme is educate, advocate, and act now, and it highlights the need to educate stakeholders about antimicrobial resistance, advocate for bold commitments, and take concrete actions to prevent antimicrobial resistance. So in keeping with this theme, we are privileged to have two of our colleagues with us today to share their insights on combating antimicrobial resistance, focusing on two vital aspects of this fight. Our first presentation is Asymptomatic Pneumonia, Re-Evaluating the Whys and Whens of Respiratory Culture by Dr. Helmi Sulaiman, who will explore the diagnostic strategies for pneumonia. So as you all know, Dr. Helmi is an infectious disease physician, lecturer, and researcher in He's a product of His main focus of interest are conducting advanced research through randomized controlled trials, refining treatment strategies for infections, and optimizing antimicrobial treatment in critically ill patients by applying principles of pharmacokinetics and pharmacodynamics to enhance therapeutic outcomes. Our second presentation is titled Breaking the Chain, Multimodal Hospital Environment Hygiene Strategies to Combat Antimicrobial Resistance Transmission in ICU by Dr. Alwani, who will focus on the critical role of environmental hygiene in controlling the spread and resistant organism in intensive care unit. So now Dr. Alwani received her medical degree in USM and joined the infection control department in 2022. She is basically my right hand and left hand. In 2023, she earned her certificate in infection control from the Certification Board of Infection Control and Epidemiology in United States. Her main interest lies in the transmission of hospital-acquired infection, and she's actively involved in empowering healthcare workers in infection prevention and control. So without further ado, I invite Dr. Helmi to give the first presentation, which will be followed by Dr. Wani's presentation. Thank you.
Good morning, everyone. Thank you, Sasheela, for the kind introduction. So as Sasheela has said, that we will shift here from a clinical case to today's presentation. So I am tasked to present this topic on asymptomatic pneumonia. So somewhat a misnomer because pneumonia should not be asymptomatic. So I will walk through you through these re-evaluations of the respiratory culture as to when and why we should actually be sending it out or sending them out. So pneumonia is a common and a deadly condition. So this is a Lancet paper that was published just 2 years ago, looking at estimated cases of pneumonia in 2021. It was estimated that 344 million people were diagnosed with pneumonia, leading to over 2 million deaths in 2021. So this is data from our world data, looking at the estimated cases of estimated death rates due to pneumonia per 100,000 people, and the rate increased as the shade become darker. And this is a bit difficult to see, but let's see it through a graph. So you can see that in Asia, in totality, you can see that the rate of death have increased over the years. But how does Malaysia fare in terms of Asia in total? So you can see that the death rate from pneumonia in Malaysia is very high, but it's a bit difficult for us to just pick up Malaysia from the Southeast Asia and then compare it to Asia. So when you look at Singapore, Singapore also have a high rate of death in terms of for pneumonia from 2000 to 2021. And how about other countries in Southeast Asia? So you can see that the rates are quite high for all the countries, especially Philippines, Singapore, and Malaysia. And Vietnam has a low rate of death due to pneumonia. But I think this could also be a reflection of underreporting in terms of the death rate, in terms of pneumonia, as well as the estimated death rate from 2000 to 2021. So we can so pneumonia diagnosis is in hospital patient is increasing, and the increased pneumonia cases is disproportionate versus other infections such as diarrhea or skin infection. And the reasons being because the reasons that could drive this would be increasingly frail patient population, increasing complex patient like patients who are mechanically ventilated and receiving immunosuppression. But we cannot deny the fact that there is also heightened sensitivity of contemporary diagnostic modalities, including the new and upcoming multiplex PCR like BioFire. And there is also lack of standardization in the diagnosis of pneumonia. So when you look at these cases of pneumonia, you somehow wonder whether these patients are truly having pneumonia or not, or they are having other infection or non-infective cause causing the patient to have this respiratory problem. And that's why it is important for us to make sure that we make a correct diagnosis when it comes to pneumonia. So it has to actually come or start with symptoms, and then signs such as palpitations on examination of the lungs, and then coupled with radiological changes. So this is something that we learned even from, start from the medical school. But what is happening now on the ground? I'm not actually focusing or blaming people for doing this, but I think that this is something that is happening on the ground in many of our rounds in our daily practice, where we actually push all the symptoms, sign, and radiological changes to the right, but we actually start our round with culture result. And this is one of the ways that we actually shine more focus on the culture result compared to the symptoms, signs, and the radiological changes. And how do we do that? So this is one of the cases, one of the hypothetical cases where a doctor may actually put a highlight on the culture rather than the patient. So like this case, my patient, Mr. Zazu, was admitted to the hospital 5 days ago. But rather than go to the patient, they will actually start with, now he has a fever with pneumonia because the culture grew Asymptomatic Pneumonia. And this will actually cause a ripple effect where people or where physician will then start antibiotic for this patient just because the sputum culture grew Asymptomatic Pneumonia. And this has been documented and reported in multiple studies. And we know that that our lung is not a sterile site. So we know about asymptomatic bacteriuria, but there is now this new term called asymptomatic bacteria sputia, where in a ventilated patient, the longer the patient is receiving ventilation, the higher is the rate of recovery of organism from this patient. Like in this study, looking at mechanically ventilated patient, close to 50% of the patient have positive bacterial colonization at baseline. So even on day one, you have 1 in 2 of these patients having a positive culture. But by day 3, most of these patients would have positive culture, even without any symptoms and signs or radiological changes to suggest that the patient is pneumonia. And what is more important is that the presence of the positive culture in the respiratory sample incentivizes pneumonia misdiagnosis and treatment, meaning that physicians tend to start antibiotic, and once they start, they will not stop until 5, 7, 10, or 14 days. And this is another study looking at medical and surgical ICU, where more than 50% of VAP diagnoses were incorrect. And again, a sputum collection on day 3 of ICU admission increases the risk for antibiotic discontinuation by 3 to 2-fold. So this highlights the issue of sputum collection and interpretation of the result when these were available, especially when you're actually changing from one team to another. So it's very difficult if you actually collect the culture or collect the sputum collection without having an indication to do so, because the next physician might think that this culture needs to be treated. And pneumonia overdiagnosis is not only limited to ICU, but in hospitalized patients too. So this is a paper just published a few months ago looking at 48 Michigan hospital. They look at adults who were misdiagnosed with pneumonia. So there is over 2,000 patients or 2,000 adults had this misdiagnosis, and 90% of them received a full antibiotic course. But they did not. This antibiotic course or full antibiotic course did not improve the outcome. But the patient who received this antibiotic developed more adverse drug reaction and drug events. So this is a concept that has actually been shared or been talked about, diagnostic stewardship. We know about antibiotic stewardship, antimicrobial stewardship, which is the yellow one or the orange one. So we talk about prescribing guidance, microbiology report review, and clinical response and adverse event monitoring, and appropriate antimicrobial regimen in terms of dosing and treatment duration. But now, we also need to think about the way we actually diagnose patients, the way we send samples, starting from patient evaluation, patient testing, the diagnosis and empiric therapy, and even then, we need to talk about the test result interpretation. We cannot just look at the culture and treat the culture. We need to go back to the patient, ask ourselves why the sputum collection was collected, and how was the patient when the patient sample was collected. Is this sample now is a significant sample that I need to act on? Okay, so I put a highlight here. So for pneumonia, I think that we need to actually think about the initial patient evaluation and patient testing. Again, symptom, clinical suspicion, and decision to test. And before we collect or order the sample collection, we need to think about whether the patient requires the testing in the first place. So diagnosis stewardship, the goals and target is mostly to decrease overuse, like inappropriate urine or respiratory culture collections, which we are discussing today. But sometimes we also need more testing. For example, in patients with Staph aureus bacteremia, we asked the primary team, we asked the primary team to repeat blood culture, and I hope that this is a culture that we are doing for patients with Staph aureus bacteremia, because they tend to actually have invasive infection and cause abscesses. So the goal with diagnostic stewardship, like antibiotic stewardship, is not the philosophical less is more, but rather we should think about optimal testing approach for our patient. And in some patients, it may require more testing, but the overall arching aim is actually for the patient's to the betterment of the patient outcome. And why do we do this? Because diagnostic errors can harm our patient. Overdiagnosis, pneumonia, like pneumonia and UTI, can lead to, as we can see just now, adverse drug reaction without improvement in the patient outcome. Misdiagnosis, because in a report, it showed that close to 800,000 Americans become permanently disabled or die annually because of the dangerous disease being misdiagnosed. And it can also cause increased healthcare costs. And finally, inappropriate antibiotic therapy. And inappropriate antibiotic therapy is important because, as Sasheela said just now, it's not something in the future, it is happening now. We are facing the burden of antimicrobial resistance. In 2019 alone, close to 5 million people died due to AMR. And of this, 1.27 million of these deaths are attributable to bacterial AMR. And then when we look at the death attributed to vector AMR, Southeast Asia is here. And the biggest drivers for this, for the antimicrobial resistance, the misuse and overuse on antibiotic in both humans and animals. And this is a nice paper illustrating the drivers for AMR. You can see that both human and animal antimicrobial misuse and overuse are the biggest driver for AMR that we are seeing currently and also, I believe, in the near future. So this is going to be my last few slides. If you have a pneumonia, if you make a pneumonia diagnosis of a patient in front of you today, we can try to improve our approach in our daily round. So rather than putting a highlight or emphasis so much on the culture, we need to go back to the patient and go back to the basic, where we can start in our round, or we can actually teach our juniors and then ask them to present it such a way. Mr. Zazu was admitted to the hospital 5 days ago, and he had a HAP 2 days ago, evidenced by fever, productive cough, hypoxia with palpitation on his left lung, and chest X-ray showed the following. And then only said whether the sputum was positive or not. And in this case, the sputum that was collected 2 days ago grew Acinetobacter baumannii. Okay, so last few slides, we just want to actually highlight, or we just want to announce that next week we're going to launch this UMC antimicrobial guideline during our WAAW session on next Thursday. So please come and join us. And then we also have this new guidelines for the MDRO management. And finally, we will have this a conference that will be happening in 2026. I know it is in 2026, but just mark your calendar. It's going to be an exciting event and conference. Thank you all.
Thank you very much, Helmi. We won't take any questions now. We'll go straight to Wani, and at the end of it, we'll take some questions if we have time. But please do type your questions in the question and answer box, and we'll try to type the answers in just in case we don't have any time. Thanks. Wani, to you.